here we go. So, as you've heard, January 1st of next year, there will be new eval codes for OT and for PT. Get this a little bit bigger here. All right. So I sent to all the rehab directors and ONSARC, et cetera, this link, this intranet pathway to some of the documents I'm going to be talking about today. So there's the pathway on the intranet. So it's available in the email that I sent earlier today, as well as on the intranet. So hopefully that'll be helpful to you. So why is this happening? I'm just going to touch this briefly because I get it that most people really don't care. They just want to know what's new and how to do it. So I'll keep it short. But CMS for a number of years now has been working to what they refer to as revalue potentially misvalued codes. This happened a couple of years ago with speech pathology eval codes, and it's happening now with PT and OT eval codes. There are other therapy codes, treatment codes, which are under review, and I don't know that they'll change the codes, but they may revalue them in terms of the formula that's used to establish a reimbursement rate. In this case, even though there are 3 new eval codes for both OT and PT and new re-eval codes, the payment is going to stay the same for each of those eval codes. And that's a little curious because they're based on level of complexity. And one would think a higher complex eval would have a higher reimbursement rate. But for now anyway, I'd say for at least the first year, it doesn't matter whether you're billing low, moderate, or high complexity, the reimbursement will be the same. However, I want to stress this. I think it's important to do your best to match your actual evaluation to the correct code, because I think in this initial period, CMS will be collecting data about these various complexity levels, and that will go to set reimbursement amounts down the road. So as with any kind of documentation, billing, and coding, we want you to be as accurate as possible. All right, so here's the first look at the new codes. The PT evaluation code 97001 will go away and will be replaced by these 3 codes. One, as I mentioned, there's a low complexity, moderate complexity, high complexity evaluation and code to go with it. The re-eval code 97002 will be replaced by 97164 for PT. Similar thing for OT. The codes we are used to using will be replaced by the codes you see here. All right, so we're going to talk a bit about what are these codes and how the heck do we choose low, moderate, or high complexity. Now, let's see if I can get – how did I do this last time? There we go. I'm going to pull up one of the documents that I sent out earlier, and this is the long descriptors for we're going to look at the PT eval and re-eval codes. Can everybody see that document?
Yes.
Can I get a yes? Yeah, okay, thank you. All right, so you see the new code numbers over there on the left. 97161 is low complexity PT eval. Now, I'm not going to read this word for word, but there are certain parts of this that are important, and these are elements that are repeated through each level of complexity, and they kind of build on one another. So for a low complexity eval, you see there's history with no personal factors or comorbidities that impact the plan of care. There could be a lot of personal factors and comorbidities and medical diagnoses, but the decision point here is how or if those impact the plan of care. An examination of body systems, so 1 to 2 elements from any of the following: body structures and functions, activity limitations, and/or participation restrictions. 1 to 2 elements, so 1 to 2 body structures and functions without activity limitations or participation restrictions. That puts you in the low complexity ballpark, that one item. This is another piece, the clinical presentation. This is important to helping you judge whether it's low, moderate, or high complexity. At low complexity, the clinical presentation is stable or it's uncomplicated and/or uncomplicated. Clinical decision-making is of low complexity. So you're using a standardized assessment instrument or measurable assessment of function. Now, the time piece, there's a typical time associated with each level of evaluation. And that, to me, I want you to think of that as the least important, all right? So it's really about everything above that that helps you assign the right code, the right level of complexity. The time piece can be helpful, but it is not, it doesn't follow that if this took me 25 minutes, it's automatically low complexity, okay? It's a factor, but it is the least important one. So moderate complexity, you'll see how this builds on what we just saw. Now we're talking about history with 1 to 2 personal factors and/or comorbidities that impact the plan of care. So that's where you look again at diagnoses and other conditions. Clinical presentation that is evolving with changing characteristics. So we go from a stable clinical presentation to one that's evolving. And clinical decision-making of moderate complexity. Time is 30 minutes, typical. Face-to-face time with patient and or family or caregivers. High complexity, now we're talking about history of the present problem with 3 or more personal factors and or comorbidities that impact the plan of care. And now you're looking at the number of, or the breadth really, of the eval includes 4 or more elements: body structures and functions, activity limitations, and or participation restrictions. And the clinical presentation now is one that is unstable with unpredictable characteristics. So this is typically a less healthy individual or more involved medical picture. And then 45-minute time. The re-eval, there you see the new code 97164, and this is not new information really. It's a revision of the plan of care. It's a review of the plan of care, retesting, and if significant changes are made to the plan of care, if there's a change in the patient's condition, et cetera, that would warrant a reevaluation, and that's the code that you would use. All right, let's have a brief walkthrough on the OT. Now, the OT criteria are quite a bit different, really. You'll notice that the times are not the same. So low complexity for OT is listed at 30 minutes, moderate at 45, and high at 60. I'm just noticing there's something strange there about the text in that document. So low complexity. Occupational profile, medical therapy history with brief history, including a review of the medical and/or therapy records relating to the presenting problem. The assessment, you might use one or two or more tools, but it identifies 1 to 3 performance deficits. And it goes on to say that it relates to physical, cognitive, or psychosocial skills. Those performance deficits result in activity limitations or participation restrictions. The clinical decision-making is of low complexity, which would include an analysis of the occupational profile, the data from problem-focused assessments, and the consideration of limited number of treatment options. So it's a fairly straightforward, I see this, I'm going to measure that, it points to this treatment or this intervention. It's few factors and fairly straightforward. The other thing about the OT definition here is that at each level of complexity, there's a description or a mention of whether or not the therapist had to make modifications to enable the patient to complete the eval. And at low level, there are no task modifications required or no assistance required to complete the eval. So I think that's a fairly important point. At moderate complexity, you'll see, again, we're looking at the profile and medical and therapy history, but this time it's an expanded review of medical or therapy records and additional review of physical, cognitive, or psychosocial history related to current functional performance. Now you're talking about identifying 3 to 5 performance deficits, resulting in activity limitations or participation restrictions. Clinical decision-making of a moderate analytic complexity. And you'll notice in that, those couple of lines there now, it includes, now the therapist has to consider several treatment options. And that could be because you've got now more performance deficits and you're going to have to address several different performance deficits. But that's going to be a more complex plan of care. And then at high complexity, same basic structure, but the review of the occupational profile, medical, and therapy history now includes extensive additional review of physical, cognitive, psychosocial history related to current functional performance. Now we're up to 5 or more performance deficits. Clinical decision-making of high analytic complexity and consideration of multiple treatment options. So that might be, just for example, let's say treating incontinence. On a high-functioning person, it may be a matter of, teaching that person pelvic floor musculature exercises, and they're going to monitor their own, do their own bladder diary or whatever. Someone who is more involved or has cognitive issues and needs more assistance, now you've got to plan out, we're going to do scheduled toileting. It's going to be more difficult to get them to do any appropriate exercises, etc. And at the, I skipped this, I'm sorry, at the moderate, there is minimal to moderate task modification required for the patient to complete the eval, and at high level, significant modification of task or assistance required for the patient to complete the eval. So that's an important piece to bear in mind. And then the re-eval code 97168, and it lays it out more clearly here. This is reflective of language in the benefit policy manual from CMS that the reeval is performed when there's documented change in functional status or a significant change to the plan of care is required. Okay, so that's all that. That's the long stuff. If you want to copy that off and carry it with you, great. I did create a condensed version of all that information. So that would be a little bit easier to follow maybe. And I'm going to try to open that up for you. Again, it's on the intranet, and also I emailed it to all the sites. Oh, sorry. I had trouble this last time, and I'm not very adept, I guess. I've lost my WebEx skills. Now I can share it with you. Let's see. All right, you should be able to see now the PT and OT evaluation coding guide. Yes?
Yes.
Thank you. So you'll see that it's really, as I said, it's condensed. You've got the personal factors, body system exam, clinical presentation, and how those change from low to high complexity, decision making, et cetera. And same thing for OT, where you're talking about the depth of review of personal information, medical and therapy, and physical, cognitive, psychosocial history, the performance deficits, comorbidities, task modification. You see how all of those progress as each through the level of complexity. So that's available to you. That's probably what I would print out and carry around, but only if it's useful to you. Okay, now, SMART, we just had an update from SMART, and we have, let's see here. I'm going to show you some examples. All right, let me get back to show you some examples of what options you'll have when you bill an eval code. There are some options for what your daily note that you write for that's going to look like. So SMART has set it up. Oh, come on, not opening it for me. I'm sorry, apologize. Let's try this. Let me just find the file. Here we go. So SMART's done, I mean, it's really a note that's built around these different elements of each level of complexity. So oh, come on. What up with this? Here we go. Now, hope y'all can see that. Let me get it a little smaller. Here we go. Daily note CPT code phrases. So if you're going to bill a PT low complexity eval, 97161, you see it's just like regular daily note documentation, where it's got part of the documentation entered, but the therapist will have to fill in where these red, where the red font is. So personal factors, body structures, enter 1 or 2, and functions, or, that says or, enter 1 to 2, functional activity limitations, etc., with whatever standardized test or measure you used that indicated stable patient presentation. All right, at moderate, now it's saying 3 or more body structures with function, activity, participation limitations of, and the therapist enters what those are. What are those limitations? Results of, whatever the test again, or the measure, show what sorts of risks or that would lead to a changing clinical presentation. So same thing for OT, and again, it's really, the progression is around performance deficits. 1, 2, or 3, 3, 4, or 5, 5 or more. So it's set up pretty well to support your decision about which code you're choosing, which level of complexity. Okay? So, if I can navigate this, I want to get back here we go, and look at some examples. I'm going to start with a PT plan of care. Theoretically. Dang it. Sorry, guys. All right. Here we go, finally. Y'all seeing that? No?
Not yet.
Okay.
No. Yeah.
That's a no?
No.
Ooh, yeah.
No.
Oh, man. Okay, here we go, I think. Thank you for your patience. I'm sorry, I'm bumbling around. All right, should be up now. PT plan of care?
Yes, it's up there.
Thank you. All right, this was billed as a 60-minute eval. So let's look at the elements here now. So for PT, we're we're going to look at body systems, body structures and functions, activity limitations, or participation restrictions. That's one of the criteria. Think about clinical presentation, stable, changing, etc., and the clinical decision making. So let's start by looking at the medical diagnosis, which is sprain of parts of the lumbar spine and pelvis, lumbago with sciatica, and weakness. And then you read the reason for referral is back pain due to lumbar strain, and you see that she reports she's been severely limited by pain with all activities. So there's some participation restrictions. Look at the medical history. So see if any of these have an impact on the plan of care. And by the way, this is, feel free to pipe up with a comment. So we've got a history of total shoulder replacement, knee surgery, osteoarthritis, degenerative disc disease, hypertension. Any of those likely to contribute to this plan of care? Back pain, I think. Hello? All right, let's keep going. Let's look at the assessment portion. So you see there that the therapist writes that the patient has pain, which has a severe effect on function. She's got poor core strength. There are a couple of objective measures there, which is great to see, a pain rating scale and a pain disability index, which indicates severe disability. And then the muscle tightness in the paraspinals into the glutes, and some information about how long she can walk before the pain gets to her. So if we went by time only, that would point us to a high complexity eval. I'm going to say I don't think this is a high complexity eval. What are other people thinking?
I agree, because she's so limited, you can't really assess that much yet.
Okay. So if we think about body structures and functions that were evaluated, I see pain, strength, I guess you could talk about ambulation, mobility. What about the clinical presentation? Is it stable, evolving, unstable and unpredictable? Can you tell?
Probably evolving.
Yeah, probably. Probably the best way. So, and I get it, you just saw all these criteria and you're just having a quick look at this, but I really think this probably best falls into a moderate level of complexity. Okay? The point obviously is that, again, time is not the deciding factor. It is a factor. It's really more about the complication and the presentation of the patient and how thorough of an eval was conducted. Okay?
I have a question, Anne.
Yeah.
On the body structures and functions,
I
mean, if I check someone's range of motion, strength, balance, bed mobility, transfers, and ambulation. That's 6 elements?
If they are three or more elements from any of the following: body structure, activity limitations or participation restrictions. I would think probably yes, if you're checking those because you can see or the patient comes in telling you that they're not normal, yeah. Had a commenter on the earlier call, and I actually agree with this, that a couple of points. One, age is a factor that probably should always be considered because it is going to change the impact the plan of care. So that's something to think about. And 79-year-olds on balance are going to present and perform and progress differently than a 65-year-old or an 85-year-old. So that is a factor to think about. But by and large, I think you might find, I'd be curious to see where people are coming down. I think a lot of the residents that are evaluated in our settings are going to, in the rehab agencies anyway, are going to come in at a moderate complexity. That's just that's not a prescription, okay? There's no prescription for how these are distributed. We're going to find that out. So let me see if I can get to the OT. Well, and I'm sorry, we could look at a lot of these. I'm just trying to get the high points and not use a terrible amount of time.
So on the SMART thing that you would calculate out of that eval, so if we're putting in then that that we did a Berg or a Canetti in that phraseology of the eval code, does that now mean that we can't bill treatment for doing those? Since they're part of the eval sentence? Or do we repeat it down in 97112 now?
So if it's part of the eval, you include it. In the eval code. But again, when I think about evaluation, I'm looking at a systems check. Okay, so you're gonna look at balance and range and so forth, and you may go ahead and later, as part of treatment, do more in-depth assessment. But I would say, if the Berg is part of your eval, include it in the time. It certainly goes to the complexity, but it's going to be hard to have. Here's where the time does matter. It's going to be hard to have a 15-minute eval and say that it's high complexity. So this is where I think we've as an industry, if you want to call it that way, I think we've almost shot ourselves in the foot here by trying to carve down eval time to only 15 minutes every single time. That's not realistic. It's not even reasonable. And it's probably one reason that the eval codes are being looked at. Because if we say with every eval that the whole daggum eval happens in 15 minutes, then the people are reimbursing us are saying, well, it's not worth very much if it only takes you 15 minutes, right? So that's why I say just do your best to sort out what the elements are of your evaluation. And now, I've also said this to probably some of y'all on the phone. you continue to evaluate. You go deeper and deeper through therapy, and that can start with the very first treatment the same day that you do the eval. So it's not like every time you're checking on something, that's assessment, and all of that can't happen in the very first evaluation of the patient. You're doing a systems review, you're identifying where the issues are, then you're going to go ahead and go deeper in your treatment sessions. All right, let's look at this OT plan of care. This was billed for 15 minutes. So this person's personal history, repeated falls, cervicalgia, and the treatment diagnosis is muscle weakness. So we see that the, let me use some of this right language from the descriptor, performance deficits. So we've got just the presentation is severe neck flexion and resting posture, difficulty holding up the head, difficulty with bathing and dressing, and later down here it addresses the fact that, where is that? I thought it was in the goals. Yeah, driving. He states that he can't drive as far as he used to be able to because of his pain and posture issues. So we see here, so we've got bathing, dressing, difficulty holding up his head, standing. You see the medical history. There is the history of falls, so to consider how that might impact the plan of care or activities, etc. Taking a bunch of medications, so you'd want to look at that as a factor. It certainly increases fall risk. And the therapist, by the way, mentions here about, I don't know if it's that last medication, but anyway, that some of these may cause dizziness and impact functional performance in therapy. So that's an important note when you're going back to look at what level of complexity are we going to bill for this. So you see there's a moderate effect of pain on function, there is a pain rating, and we've got range of motion measurements here, a number of them. These are your objective measurements. Muscle strength. I was trying to remember if this was the eval where the therapist documented making some modifications during the eval, but I don't think this is the one. Anyway, standardized test there. So if we look here, if we went just by time, we'd be saying, oh, it's just probably low complexity. But if you think about performance deficits and how extensive the review of this person's medical history is, additional review of physical, cognitive, or psychosocial history, are you still thinking low complexity?
No, more of a high based on everything we've seen.
Could be. It could be. Yeah. When you sit down and start counting performance deficits.
There's more than 4 elements. This is actually sort of a relief because over the years, we've been told by our directors 15 minutes, and then now they're getting away from that. But as recent as this spring, now that I'm a director or therapy services coordinator, one of my PTs is called out on billing a really complex eval for 60 minutes by somebody above me. So this is sort of a relief almost to be able to do this.
I do think it's going to change a little bit how people have thought about it, and it certainly makes it easier to talk about why
Well,
someone
it
would
takes an hour sometimes. Yeah.
Right, right. So it is complicated too by, you know, yeah, the reimbursement issues and where time is allotted, and I think there's some gray areas, and but yes, I think this could be helpful. So remember, though, that the OT and the PT definitions are a little different. So make sure folks are looking at the right description, because, for example, moderate complexity OT eval talks about 3 to 5 performance deficits. If you applied the PT rule to this, 4 or more elements, that puts you into high. So I think this one also probably falls more in the moderate complexity. But again, I'm not giving a prescription here. I'm just saying you see the kinds of things that therapists are going to have to think about in assigning complexity. What we don't want is people just to default all the time to moderate or to low or to high. There should be variation amongst a person's caseload, even though, as I said earlier, I do believe that we may see most or many being moderate complexity. But I don't want that to become just a default choice because it's easier. So we really want to encourage people to use the guidelines and do your best, because I think that, as I said before, how this plays out and how these various levels are distributed, I think it's going to inform what the reimbursement looks like down the line. So it's not going to be the same money for each complexity level in the future. So that's why we want to be as accurate as possible. Okay, anything else? Comments or questions?
Yes, I would like to ask a question.
Sure.
I'm thinking of a patient who would be low complexity as far as comorbidities and all of that, but maybe they come in with vertigo, and that's their main. Maybe they don't really have even any other diagnoses, let's say, but a vestibular eval is going to take quite a while. It's pretty extensive. So how will I justify my time when everything else is going to look low level or low complexity?
I think that in that case you'd go toward, for PT, you'd go toward the evolving clinical presentation idea, changing characteristics maybe, and the clinical decision-making piece. It's as you say, it's a more complex evaluation when you're managing all the variable factors related to vestibular, and you're testing this and you're testing that versus, you know, how badly is your ankle sprained, for example. So it goes to, I would say, the decision-making part and the clinical presentation on the patient's part. It's the aggregate of all those things. It's not that only 1 or 2 body structures means it has to stay at low complexity. I think it's you can consider all the aspects.
All right, and it's not uncommon if I do a complete vestibular assessment and I'm assessing central and peripheral and Dix-Hall Pike and roll tests and doing maybe a treatment. I mean, I will spend an hour and a half to an hour and 45 minutes, most of that being eval time. Can I put all of that down just under eval?
This is where, you know, I say the gray area and the sticky business is, because that'll be noted, and it's because the reimbursement for the eval isn't going to cover all that time. That's a thing I'd want to talk to you individually about, look at the situation and stuff. It may be that it's absolutely accurate and the only thing to do, put your time there. It may be that once you establish the initial issues, that some of those later assessments could be attributed to a diagnostic therapy session. I know that's not a cut and dried answer.
Yeah.
Because there are issues of reimbursement, you know. I mean, it's a razor edge we're talking about here. I don't want anybody to do anything that's not appropriate at all. And that's why it gets hard, because reimbursement doesn't cover the time, doesn't pay for evaluating therapist time when we get past an hour for sure. So that's why there's conversation in the therapy world about how much of that's true evaluation and how much of that is really assessment, much like what happens in many treatment sessions. So, anything else?